Hello, everyone, and welcome to another episode of the Overcoming Chronic Illness podcast. My name is Dr. Brian Rade, and I'm a naturopathic doctor. And I am excited to be joined today by another one of my naturopathic colleagues, Dr. Sanja Tambric. Dr. Tambric is going to be speaking with me today about a topic that I'm really interested in. It's something that's been kind of a bit newer on my radar in the last several months. It's something called vitamin D receptor resistance. And so we're going to get into all the nooks and crannies of that, but it's something that I've started working with my patients, testing them for it, and they've been working with the treatment for it, and starting to see some positive clinical results with some cases, and something that I'm quite excited about. So very happy to have her on the podcast. Just before she joins me here, I just wanted to let everybody know who's listening that I do have an online course for the general public. It's called the Overcoming Chronic Illness course. And basically it's something that I put together maybe maybe 1.5 years ago, maybe not quite 2 years ago. And it's essentially an 8-module course that goes over all the major topics that a lot of folks with complex chronic illness are dealing with. Things like mitochondrial dysfunction, chronic infections, heavy metals and other detoxification issues, mold illness, histamine issues like mast cell activation syndrome, and many others. And so within these modules, I go over them in quite a lot of depth. I mean, not getting into like research studies and this and that. Like it is a course that's designed for the general public, the general populace. Of course, the general populace probably doesn't think much about complex chronic illness, but for folks who are dealing with complex chronic illness, it's for lay people. But I've had some really humbling feedback from some of my patients who are, I would say they've been steeping in the this world of complex chronic illness, doing a lot of digging, reading research articles, like attending courses and summits and all of that, and had some really humbling feedback, just saying that this is something that tied a lot of things together for them. It brought an additional level of insight that they hadn't received from other sources that they'd accessed information from before. So it seems to be quite useful even for folks who are quite well versed in this realm. So if the course is something that you might be interested in, I do offer the first 2 modules of the course at no charge. If you sign up for my mailing list, then you get when you get your welcome email from that, then it will give you a link to the first 2 modules so you can access those. And one thing I forgot to mention is that with each of the modules, there are these, as I call them, cheat sheets that folks can either email or print off and give to their clinicians. Because one of the challenges that folks run into is that they might have a clinician who's really mold savvy, but they don't know a whole lot about SIBO, or they don't know a whole lot about heavy metals, or they don't know a whole lot about Lyme. And so each one of the modules has a cheat sheet that is designed to be given to one's clinician to give kind of an overview of the topic at hand, tests to consider, treatment ideas to consider, etc. And so that's another feature that's kind of built in with this course as well. So for those first 2 modules, the information is those first 2 modules are available at no charge if you're interested in checking it out. The link to sign up for my newsletter is in the show notes. If you're listening to this as a podcast, or if you're watching this on YouTube, then it's down in the description below. So without further ado, I will just pause the recording for a second, and I'll be back in 2 shakes with Dr. Tamburic. All right, everyone. So I'm back now with Dr. Tamburic. So thank you so much for joining me today.
You're welcome. Thanks for the invitation.
Yeah, my pleasure. And yeah, I've been looking forward to this one for a while because, as you know, we've corresponded a little bit about the vitamin D receptor resistance, and it's something that I've been testing a lot of patients for. Some patients have started on the treatment, so I'm excited to pick your brain because it's still so new for me, but I know you're an old hand at it. So just before we jump into the meat and potatoes of talking about this topic, would you mind just giving the listeners a bit of a brief background on sort of who you are, what your practice is like, and how you got into working with treating patients dealing with complex chronic health issues?
Mm-hmm. Well, thank you. So I'm a naturopathic doctor practicing in Vancouver, British Columbia, here in Canada. I've been in practice for 17 years now. prior to that, I studied psychology, and prior to that, I studied conventional medicine. So what led me to focus on autoimmune diseases is my personal journey when I was in medical school, and also patients that I was helping as an ND. Basically, even when I was in school, one of my mentors told me that I will be focusing on autoimmune disease. So so that became true. So one of the patients who has MS asked me to follow her on with the vitamin D protocol, which is also called Dr. Coimbra's protocol. And that's how the journey started. Basically, it doesn't only treat MS, but it treats all majority of chronic diseases, especially autoimmune diseases. So that's the focus of my practice.
Yeah, that's fantastic. And roughly how long you've been working with the Dr. Coimbra's protocol?
So since 2006.
Okay, great. And I don't remember now off the top of my head, but roughly like how long has he kind of been working with the protocol himself? Like how long has this been out there for?
2016. Yeah. So I think he's been working with protocol about a decade now.
Mm-hmm.
And I've been working with it for 7 years. So I got trained pretty early on.
Yeah.
Yeah. So the protocol has been amazing. And those that are not familiar with that should get familiar, because it's a great replacement for all the toxic drugs that patients are on and that are not working. And with the proper education and training, all doctors should start using this protocol, because there's so many patients that need help out there. And I think in Canada in particular, it hasn't been that popular as it has been in the US and Europe, and the rest of the world, obviously Brazil.
Yeah.
So we'd like to invite, if there are any of our colleagues or other people who are in medical profession, they should, I would like to encourage them to start using this protocol.
Mm-hmm. Yeah, and my understanding is unless someone finds a very a mentor who's generous with their time, as you have been, sharing resources with me, which I greatly appreciate. Otherwise, it's just traveling down to Brazil to study with Dr.
Yes, at
Coimbra
this time,
directly, right? Yeah. So
yes, but Dr. Coimbra volunteered his time with all the doctors, and I'm so thankful for his knowledge and time and that he shares with everybody. And he's burnt out pretty much, so it is very difficult. But we all here and happy to share the knowledge. And yeah.
That's great. Do you know how many clinicians are in Canada that are using this protocol roughly?
So it's just myself right now, and you're the next one.
Second generation.
Second generation. So yeah, we need more people for sure.
Yeah. Two's not enough.
Yeah.
Do you know roughly how many clinicians are in the U.S.? As I know a lot of our listeners here are from the U.S.
Yeah, I don't know exactly the number, but there are some on the West Coast, in Washington, in Arizona, and then Florida, from what I know. Not too many, not too many either, but more than in Canada.
Right. Yeah.
Yeah, the list can be found on Dr. Coimbra website with all practitioners. Yeah.
Right. Yeah. And I'll post a link to that in the show notes for folks for convenience. But yeah, that's how I came across your name. So yeah, that's glad you're on there. So just for listeners, as I know some folks, I've been chatting about this a bit in my social media and my newsletters and things, but I think a lot of folks are just not really familiar with what is vitamin D receptor resistance. So would you mind just giving an overview of what that issue actually is?
So to begin with, we still haven't answered the question, is it the disease that has caused the vitamin D deficiency, or is it the vitamin D deficiency that increases the risk of autoimmune disease? So when we take that into account, then we can start thinking about, why do we have VDR receptor resistance? Is it the cellular toxicity that is preventing the absorption of vitamin D? Is it the right form of vitamin D? Is it genetic mutation? So this is what's happening. So the way there is kind of way to overcome that, and with everything that we have in our toolbox, we can use to first of all remove that cellular toxicity, and then see if the absorption is increased. We can increase the dose of vitamin D significantly to overcome that resistance as well. So we have to take into account the whole body and the state of health or state of disease in order to overcome that issue. So I think that environmental toxicity plays a huge role in this resistance. I think that environmental toxins and glyphosates and other toxic chemicals that are found in our food and environment affect these receptors. Because this deficiency has been around since I was a student. That was one of our questions from what I remember. This was the biggest deficiency, right, in the world. And as we know, the increasing level of toxicity in our world, and also the ozone layer. So the heart of the ability to absorb vitamin D.
Yeah. So maybe just to could you describe for listeners a little bit more, like, so the idea that like there's this resistance, like I understand there's kind of this more speculation around what's actually driving the problem. Is it kind of a chicken or the egg thing, maybe, with the receptor resistance? But what exactly is happening, like with vitamin D receptor resistance itself, like at the receptor level?
So the vitamin D doesn't get absorbed, and so it doesn't do its job. And when you increase the dose of vitamin D, you can push the body to change that resistance.
So, I mean, an analogy I've been using with my patients, and I might have my things wrong, so please let me know. I've been kind of using the analogy that, a person might have lots of vitamin D in their bloodstream, and yet it's not actually working on a receptor level. So the analogy I've been using is, if a person had, $1 million in their pocket and they want to go on a shopping spree, but none of the stores will actually take their money. It's like they have all this money, but it's not doing them any good. Like, I have all this vitamin D in my blood, but it's not actually binding to the receptor, or when it binds to the receptor, it's not actually transmitting the signal to the cell to tell the cell to reduce inflammation or improve mitochondrial function or reduce hypersensitivities to things. Is that a fair way to describe it, or am I?
That's correct. That's exactly what's going on. Yeah.
Okay, great. Yeah, I know, pardon me, when I first start talking to patients about this, sometimes they'll say, well, like, I had my vitamin D tested and it was like at 150, which that, using, Canadian units / non-American units, that would be around, what is that, divided by 2.5, whatever that number is. So maybe around.
We want it's yes, 80.
80. Thank you. Yes, 80. So if, and so they would say, oh, well, that's, like, I have good levels, and yet, like, so I must not have this issue. And it's like, well, no, like, you have plenty in your bloodstream, but it's not actually working on a cellular level, is the way I've been describing it.
Correct.
Yeah.
Correct.
Okay, great. So in terms of what you see in clinical practice, I like to talk about autoimmune conditions first, and then if we could talk about some non-autoimmune conditions, if you don't mind. So which autoimmune conditions have you seen the most benefit for in terms of using this protocol with?
So multiple sclerosis has had the best response, because there's most of the research has been done in multiple sclerosis. And if you look at the receptors, they're found on neurons, and they help regenerate. The vitamin D helps regenerate myelin. So the most obvious results are seen in those cases. In rheumatoid arthritis, in psoriasis, psoriatic arthritis, vitiligo, even though that's a slower process, because you expect to see some pigmentation coming back, and that's really an objective symptom, right? However, at the cellular level, you are stopping the progression of disease, which patient is not aware of, because they're only relying on the visible changes. I've worked with transverse myelitis, all kinds of other autoimmune diseases, diabetes 1. There's more research needed in that area. We know that it reduces the blood sugar spikes. However, it is really hard to do research on diabetes 1 without the use of insulin to know exactly what's doing the work. But amazing results with multiple sclerosis, amazing.
Yeah. Would you mind maybe just giving like a couple of little clinical anecdotes, like in terms of what you've seen, like in terms of some amazing results with MS?
Yes, so with MS, obviously we know there are different grades or levels of the damage and diagnosis. There are relapsing remitting MS, which has the highest response to the therapy. Also, the response will depend on the time the patient has had the problem. The sooner you catch it and start with the protocol, the better response. And some patients who have been diagnosed with relapsing remitting that started the protocol within months of diagnosis without starting the therapy had an amazing remission. And within 2 months, their symptoms would go away. The electricity, the hermit sign, their walking would improve, and things like that. So also patients who decided to stop the drug and do the vitamin D also had better response than those that were on the drug and on vitamin D, because you're kind of trying to pull the opposite sides with the treatment. So yeah, I can't say that many people who are in primary progressives or secondary progressive have started walking after, but definitely their MRIs have shown termination of new lesions or progression in general, which is definitely the goal of this therapy, right? It's not cure for all. Let's make that really clear. It is like a type of a steroid hormone. It's not just a vitamin. So if we think that, then it will suppress the further deterioration and progression of the disease, which is the goal of this therapy, right? Yep.
That's great. Excuse me, just a quick little follow-up question to that. As I have couple of patients that with an MS diagnosis who've been excited about me chatting with you, and they're looking forward to this interview being published. So for folks with, say, an MS diagnosis, and let's say they have mild to moderate symptoms, they're certainly not wheelchair bound or anything like that. If so, say there's a case where this protocol is initiated, and let's just say hypothetically that there's a 25 to 50% improvement in clinical symptoms, and they kind of hit a plateau there, which is pretty darn amazing in the grand scheme of things. Then they find the right dose to kind of stick with their vitamin D. In your experience, or from what you know from Dr. Coimbra's experience, would it be expected that those patients at the right dose of vitamin D would kind of maintain that level of improvement long term, or would it be more common to see like just a slower degradation, like a worsening over time?
So the patients in general, once you find that plateau and that dose that works for them, would maintain their state. If there are any insults from the outside, mental, emotional, physical, flu or a virus or an infection, or use of antibiotics for an infection, that may temporarily cause a relapse. But we manage that with the change of the dosage temporarily, and then they can go on their maintenance dose. In some cases, I've had patients, for example, with rheumatoid arthritis as well as MS, that were able to lower their dose even lower than what their plateau dose was if they made other lifestyle changes.
Okay, great.
Right.
That's great.
But for most of the patients, they will have to stay on some higher, relatively higher dose of vitamin D for a long time, unless they have a huge miraculous healing.
Okay. And actually, that was going to be one of my future questions here. So, since we're on this topic already, is that the case with patients who have non-autoimmune conditions as well? That they would typically need to stay on some type of a higher dose of vitamin D long term, or are there other conditions, like if, say, a person has mold toxicity or chronic infections, like with Lyme disease or whatnot, would they get to the point where, like, once the infection's fully cleared and all that there, or the molds finally all out of their system, would they get to the point where they don't need to stay on the vitamin D at a high dose long term?
Correct. They won't need to stay. Yeah,
Okay.
it's mainly for autoimmune diseases
Okay.
in order to actually block the inflammatory marker.
Right. Okay.
Yeah.
Great. And so another question is, in terms of, listen, we talked about autoimmune conditions that you've seen this protocol benefit the most. What types of non-autoimmune conditions have you seen the most improvements with?
With osteoporosis, for example, with sports injuries, with depression. That's one of the main non-autoimmune disorders that vitamin D helps. If you have somebody who has been depressed, definitely check their vitamin D levels. I think that's even been accepted in the conventional world. Regulating blood sugar levels in general, like diabetes 2, which is non-autoimmune, also helps regulate their blood sugar. So musculoskeletal, cardiovascular, right? Contrary to the belief that high levels of vitamin D actually block the arteries, is not very true. If it's used properly, it will decrease the inflammation in the vessels. It will lower down cholesterol. So yeah, a lot of metabolic conditions, cardiovascular, musculoskeletal, including osteopenia, osteoporosis, injuries, in general immune system, right? Without treating the autoimmune component. Yeah, obviously colds and things like that.
Yeah.
So depression is huge. Also, I remember Dr. Coimbra saying, all those students that fall asleep during lectures, they're all deficient in vitamin D.
Okay. Duly noted. And would that include like depression just in general, or be more like seasonal affective disorder type patterns, or like just year-round depression?
In general, not just SADs.
Wow.
Yeah.
Okay. Yeah. Is that, I mean, what percentage of the time would you say that if you have patients who are depressed, and you run the testing to determine if they have vitamin D receptor resistance, like how often is it coming up in that patient population?
Actually, very often you'd be surprised.
Yeah. Like
I think majority of people are
yeah.
deficient in vitamin D. They don't have the optimal levels anyway, even though, like we said at the beginning, they're within the range. It's just impossible. Majority of people spend, regardless of how healthy they are and how healthy they're eating,
Mm,
majority of people are working, right, full time, and they're spending time indoors.
mm-hmm,
And just and in Canada, especially for us on the West Coast, it's just
mm-hmm.
not enough sun exposure.
Right. Um, and so in terms of the kind of just with the depression, the response rate, like, so, majority of patients that you test, they wind up having, the objective signs on lab results of having vitamin D receptor resistance. What percentage of patients roughly would would clinically improve significantly? Like, is it the majority that improve with vitamin D
So I
repletion as
can't
well?
say percentage wise, but majority of patients improve. When I put them in vitamin D, I would put them in 10,000 IUs daily,
Mm-hmm.
and their energy levels will improve. Their overall functionality would improve, of course,
Right.
without the things that we introduce, but that's the major
Mm,
player.
right. In
Of
those
course, it's
cases,
not going to replace cognitive behavioral therapies or
sure.
counseling or other things.
Right, right.
But oftentimes there are these nutritional deficiencies. There's also other work of Dr. Marty Heinz, who is neurologist and researcher, who says that all these mental health disorders have nutritional deficiencies.
Mm-hmm.
So that's the main cause of their disorders.
Right.
The deficiency that may be putting into that state of depression, and that affects the rest of your lifestyle, right?
Right.
The way you communicate. So, yeah.
So in those types of cases, like if say a patient walks in with depression as one of their chief concerns for seeing you, would you generally bother testing them, or would you just kind of
I
say,
would,
"Oh,
I
well,
test most of the people.
yeah,
Yeah.
yeah, okay."
I do like to test, yes.
Hmm. And
Better for a patient to know also than they
mhm.
trust that.
Sure. Yeah, it always helps to
Yeah.
see it on paper for sure. And I have a couple more questions for you about some non-autoimmune conditions, but this is a good reminder to myself to mention that nothing that we're talking about today should be construed as medical advice. This is all for informational purposes only. If you need any medical advice, please talk to your personal healthcare provider to get that advice. So just clarifying that for all the listeners out there. Um, One other question I have for you about a non-autoimmune condition. Have you seen vitamin D receptor resistance much in patients with polymyalgia rheumatica?
Yes, yes,
Hmm.
yes. Lately, I've been seeing more and more of those kinds of patients.
Yeah, me too. Yeah,
Yeah,
it's been more common.
yeah, yeah.
So, and then in terms of, I know we kind of briefly touched on it a few minutes ago, but in terms of, say, mold toxicity or chronic Lyme disease or other chronic infections, Epstein-Barr virus reactivation, different conditions like that, uh, how often would you say you're finding vitamin D receptor resistance being an issue for those types of patients?
Like I said, in majority of patients that have these types of chronic diseases or
Mhm.
toxicities, their levels would be low
Right.
because their receptors are occupied by toxins, right? So vitamin D cannot bind, right?
Hmm.
With Lyme disease in particular, some people out there in our world believe that all MS is actually Lyme. I'm not making that statement. I'm just saying what
Sure.
has been found in research and what
Yep.
some people are thinking. So those people that have MS symptoms due to Lyme and actually on MRI have lesions in the brain, oftentimes will require longer supplementation with vitamin D
Hmm.
in order to manage their symptoms or prevent new lesions in the brain.
Hmm. Okay. And just one thing I don't think we've touched on yet is just if you wouldn't mind explaining to the listeners how, like, what the objective test is to determine if somebody has vitamin D receptor resistance.
So we do 25 hydroxy and 125 hydroxy, two types of vitamin D. And we also test for parathyroid hormone function and calcium levels.
And without getting into the details of it, but what are the types of like so a person comes back, say they're 25 hydroxy vitamin D, which would be the type that's most commonly tested for. So let's say that looks really good. That's mid range or upper end of normal. What would be some of the abnormalities or the findings of the parathyroid hormone or the 125 hydroxy vitamin D that might come up where you'd say, oh, it looks like we might be dealing with a vitamin D receptor resistance here?
So oftentimes their PTH levels would be higher, not necessarily out of range, and also 125 would be higher, but the 25 hydroxy would be in the normal range.
Mm-hmm. Okay. And then, as say a patient is, so the patient comes back, let's say they have, multiple sclerosis or they have, mold toxicity. Let's say their levels come back, they have elevated 125 hydroxy vitamin D, they have elevated PTH or like higher than where it should be. So they're put on a higher dose vitamin D regimen. How would the labs be tracked? Like say at a next step to see if the numbers are coming down. Of course, we're hoping the patient's feeling better, but what would we be looking for clinic or objectively with those lab testing findings on a follow-up test?
So yeah, the follow-up test should show change in PTH levels, should be going down, and with 25 hydroxy levels will be going up significantly if they have a good response.
Right. Is there ever a case where, or have you seen cases where, say, the vitamin D, like say the 25 hydroxy vitamin D level gets to the point where, at least labs that I'm used to seeing, up to a certain point, they'll say we can't detect beyond this number. Like usually it's like greater than 350 or greater than 400, depending on the lab. So their levels will get to that like very high, like, can't detect higher, levels of vitamin D before you actually start to see the PTH dropping. Or does the PTH always start
That's
dropping
actually quite
before?
normal.
Oh,
It's
is it?
quite normal to go into these, what they call toxic levels of vitamin D, beyond detectable range in some labs. And that's quite normal. And not to be worried about that if we see change in PTH.
Right. With your with the labs that you're used to seeing, do they typically report it as potentially toxic, or do they always say that it's toxic when it's above a certain amount on the report? I'm just curious.
Oftentimes reported it's toxic.
It does say toxic, eh? Yeah. Yep.
Then you get a call or a letter from the doctor or a note that
Right.
the patient has toxic levels. So
Right. So to my understanding, the potential toxic effects from vitamin D would come from hypercalcemia, so too much calcium in the blood, and just in your experience, where some of the folks that you've worked with are taking very 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 high levels of vitamin D. How often is it that you see actual hypercalcemia in the bloodstream?
I would say 10% of patients have hypercalcemia. And that may have different reasons. That may happen due to different reasons. But there are also patients who are on hundreds and 150 and up to 200,000 IUs, and they don't have hypercalcemia. So we really have to look is what's causing hypercalcemia. Is it just a vitamin D, or is it the water they're drinking? Is it that they're eating too much calcium, or that they have heavy metal toxicity that's causing this?
Right. And with some of the side effects of, or the symptoms, I should say, of hypercalcemia, is because the big concerns, at least in my mind, of what I recall from naturopathic school and studying for board exams and all these things, is if hypercalcemia progresses to a certain point, it can start to have heart rate irregularities, can start to have mental confusion, like it can be pretty darn serious. The patients that you have seen, like say the 10% who do develop hypercalcemia, do they kind of go from like feeling okay to like having those extreme symptoms, or do they start having some low grade symptoms along the way? And if so, what would those initial symptoms typically be?
Actually, majority of my patients who have had hypercalcemia was just detected on a regular follow-up lab work without any significant symptoms. They're milder symptoms. If they do have, may have milder symptoms, like they would have more cramping, or or they would feel more fatigued suddenly, or they'd be more thirsty. That's kind of one of the symptoms. They would experience more dryness in general. I haven't really had experience with this extensive thirst not relieved by drinking water, which is kind of one of the telltale signs if you had hypercalcemia.
Right.
Mainly people have had fatigue and dryness a little bit, and cramping, increased cramping suddenly.
Okay.
Can't walk again as well as they did before.
Right. And I know one of the other concerns.
But some people would actually feel great. Like yesterday, I had a patient. She's a 47-year-old female, and she was actually feeling great after we've increased her dose of vitamin D. Majority of her symptoms have actually resolved. And when we did the lab, she had mild hypercalcemia, right, without any obvious symptoms. So it's really important to do follow-up lab work,
right,
especially with 24-hour urine.
Right. And I know another potential side effect of having elevated levels of calcium, maybe not actual full-blown hypercalcemia, but just having more calcium, in the bloodstream in general, filtering through the kidneys. There's some risk of a possible increased risk of kidney stones. I know that's something that was in the notes that you sent me from Dr. Coimbra's recommendations. Do you know how often it is that folks doing this protocol have develop kidney stones? Is it quite a bit more often than the average person?
You know what I've noticed, I had only few patients who have developed kidney stones, very few patients out of hundreds who had kidney stones develop actually during protocol. The thing is, we actually, unless we order an ultrasound before the start of the protocol, we don't know if they've had stones before and it was just an aggravation. Some cases I've had with people where GFR has gone down, the filtration of the kidney or kidney function has decreased, which can be recovered really easily, which we've done in the past. So with the kidney stones, it's not as common as you would think, right? It's primarily due to the already existing condition that may have just been aggravated, and patient hasn't really been fully compliant with the protocol requirements.
And would that be more around not staying hydrated enough, or they're eating too many higher calcium foods?
Correct. Oftentimes they're not hydrated enough, which I understand. It's a challenge for MS patients, a huge challenge, because they deal with urinary incontinence oftentimes and urinary bladder.
Okay.
Yeah, but it's very, very important to stick with the protocol guidelines, and then there will be no problems.
Okay. Actually, one question.
Diet is very important, as we know. Because lots of foods contained that are healthy for us, if not cooked and consumed properly, have high levels of oxalates, and it's actually oxalate binding to the excess calcium that's been filtered through kidneys that creates these stones. Right.
So is it generally recommended to try to avoid higher oxalate foods?
But not necessarily. That's been misunderstood in general, and I'm speaking mainly of the green leafy vegetables that are really good for us. It's how you eat those vegetables. They're not meant to be eaten raw, because in raw states they have high levels of oxalates. Once they've been cooked, steamed, stir-fried, whatever, it deactivates the oxalates, so they're no more problem for us.
Okay, great. And kind of circling back to just a question from earlier, I forgot to ask, because I know one of my patients who's very, very excited about getting the ball rolling with this protocol. She has vitiligo, and I know you mentioned that it can be kind of a longer process there because of the skin depigmentation and whatnot. Generally speaking, with vitiligo, how frequently does the correct dose of vitamin D kind of like halt the vitiligo in its tracks? Like I understand the repigmentation might be a long process that might only reach a certain point, but yeah, how often would it kind of stop the progression of further vitiligo spreading?
It's very effective. There's actually a paper that's been done specifically on vitiligo.
Oh.
Yes, with the use of high doses. This was done by another doctor endocrinologist that works with Dr. Coimbra in Brazil.
Mm-hmm.
And they've been successful with that disease in particular. So very quickly, these patients respond. Like I said before, it's just really we can see improvement in response with the lab without objective other I should say subjective symptoms or observation of the skin, right? It's
Mm-hmm.
just people generally start feeling better, their energy levels increase, and there's no more new depigmentation happening.
Mm-hmm. And
So in the research, it has been proven to work for vitiligo patients.
yeah, that's great. And say for a patient with, say, vitiligo or other, maybe other conditions where, I mean, with vitiligo, if it's kind of a matter of like, okay, so it's not spreading more, so I'm at my certain dose of vitamin D. I see that my parathyroid hormone levels come down, and it's at a good place now, like it's a appropriate ratio with the vitamin D level. At that point, would you be kind of just monitoring their, because clinically, if you say to them one day, like, "Hey, how's the vitiligo going?" You're like, "Well, they don't know, right? Like, it's not like you're going to be able to tell day to day how it's going if it's still being held at bay." So, would you be over the course of time trying to lower their vitamin D dosage and then periodically checking to see, is the parathyroid hormone now going up too high, or would you just hold them at a certain dose and just, say, like, let's just not mess with a good thing, let's just keep it there? How would you manage a case where the patient couldn't really tell if lowering their dose was clinically making them worse because the symptoms are too subtle or slow moving?
And you have to really rely on lab
Yeah.
and your general state of being, right?
Hmm.
Um, uh, One good thing about vitiligo is that those patients often don't have to go an extremely high dose that we use for MS,
Okay.
because it's not a such degenerative disease or life-threatening like it is with MS. So you don't have to go as high, so it's a little bit easier to manage in
Hmm.
general with a good response. So
Hmm.
in those cases, I would keep checking their PTH levels, and based on that and the overall state of health, decide whether to keep them on a fairly high dose for the general public,
Hmm.
and keep checking the levels, right? They probably need to reach certain saturation in the skin in order for the skin to change, and as well work on other things, not just rely on vitamin D.
Right. Okay.
But I also with vitiligo, I've also used vitamin D topically in addition to the oral
Oh, okay.
supplementation.
Hmm.
Yes, you can go high dose of vitamin D
Hmm.
in a cream and then apply that at least to one of the areas that is maybe more visible and see if it makes any difference.
Okay.
I've had cases who have responded to that. Same with psoriasis.
Great. Great. Um, I've had a couple of patients, two, actually three, that I can think of for sure, who seem to be very, very sensitive to vitamin D. They seem to flare, like a couple of them. I think one can take maybe like 500 international units a day and tolerates it well, but the other two just can't take any, it seems, which of course is on the one hand a bit counterintuitive because they're, not having to hide from the sun all the time. So they're obviously, they have vitamin D in their body. They can't actually be genuinely allergic to it. And yet the oral vitamin D, like they just flare like crazy. Now these patients are also sensitive to other things too, but they're not, universal reactors where they flare from every supplement under the sun. Like there are, say maybe a dozen things that they've been able to tolerate over the course of time, but they do flare from lots and lots of different things. And I'm just wondering if you've encountered patients like that, where being able to, actually, I'm thinking of another patient now off the top of my head where she can take up to, I think, about 4,000 or 5,000 IUs a day. But whenever she has tried to go up to 6,000, she gets a flare up, like her fatigue worsens, or I think maybe insomnia gets worse or something like that. So I'm just wondering, have you encountered patients like that? And if so, any advice on how to circumvent those challenges?
Yeah. So yes, I've had patients like that, not very many.
Hmm.
I had Hashimoto patient actually being very sensitive to vitamin D
Hmm.
and all over sudden messing up with their endocrine system, the physiology in general. So we've lowered it down to fairly high dose, maybe 5,000 or 10,000 at the most, and they're fine with that dose. So also, we have to look at the source of vitamin D that they're taking. Maybe
Hmm.
they're allergic to certain components in the vitamin,
Hmm.
right? Maybe they can't absorb fats, so giving lipotropic factors and supporting their fat metabolism might
Hmm.
be an issue,
Hmm.
or they really have so much toxicity that the body's rejecting because the toxins, as we know, bind to fat or they're stored in fat. So kind of working around, it's always the best before starting a protocol to really detoxify the body, right? And to make sure that the body functions properly. It's kind of
Hmm.
what we call it, reboot the body or reset the physiology.
Hmm.
Because if that's not working properly, then they will be really struggling. The other point I want to make is with those people that have aggravation after slightly increasing their vitamin D, and then they're getting fatigue, their symptoms worse, etc. It means that the dose is not high enough
Hmm.
because you've stimulated now their immune system, but it's not enough of medicine to overcome the inflammation.
Okay. Hmm.
So oftentimes, really doubling up the dose, even more, increasing, even if it's temporarily,
Hmm.
will help overcome those symptoms.
Hmm. So
Like
it.
recently, I want to mention this case. He has MS and he was in really bad state. He was pretty much bound to wheelchair, just being diagnosed. And because of his labs, I think his PTH was already low, and vitamin D was not extremely low, but a lower normal. And so his dose was maybe wasn't measured based on the proper measurements for his weight. So we started at the higher dose, but lower than you would normally based on his weight. And he had these crises along the way where he would get worse, but he persisted. And after 2 months, he actually started feeling better when the levels of vitamin D's have accumulated, and um, uh, then his symptoms started to improve. But once I've really increased his dose, he significantly got better.
Great. So it's maybe a
But
little
it's
bit.
important to do the loading at the beginning before giving the right dose
Right.
to those patients.
So for some of those patients, it's maybe a little bit counterintuitive because I know at least my mindset for the most part is like, oh, I'm starting the patient on their herbs to treat the infection and they're feeling worse. Like, oh, the dose is probably too high. I need to back off so they can ease into it. But in this case, sometimes you actually want to increase the dose further of the vitamin D to
Correct. Correct.
yeah.
Because, we need to find out if the patient is going through a healing crisis
Mm,
or it's the progression of the disease.
sure.
So that's an important, if it's just a healing crisis, you either support it with more nutraceuticals or whatever else you're using in your practice. And the patient will improve and get through that hump. Whereas if we see progression of disease, it's a different story, right?
Right.
To be able to assess that.
Right. Have there been any patients you've worked with who have needed to or done better with intramuscular vitamin D as an injection?
Uh, a lot of my patients are remote, and I haven't had the chance to really explore that option.
Hmm. Okay.
But I can't say because you have to inject into fat tissue, right? And I am not sure how well is it absorbed.
Okay. Yeah, I've had
That
a
would
hint.
be more convenient. So I just read the research showing that the levels of vitamin D have reached the same level, regardless whether, for example, patient has been taking 2,000 IUs a day or for a month, as opposed to giving them, for example, 60,000 IUs a month. In one injection, or the levels have been changed. However, in an autoimmune case, it has been highly recommended to do daily dosing as opposed to weekly high dose supplementation, which is generally done by conventional medical doctors.
Okay.
Because I have seen that with autoimmune, I think this is important. Especially, I've witnessed this in Dr. Coimbra's office, where a young teenage girl who had missed a few doses of vitamin D, just not intentionally, just happened, and didn't report that. And then she had worsening of the symptoms, and her lab also showed that she has missed doses of vitamin D, because with autoimmune patients, their levels start dropping again once they stop using vitamin D. Yeah, so it's very important to keep that in mind.
Okay, great. And just one question that sprung to mind when we were chatting here. Are you aware, like in your own experience or of any other clinicians, looking at vitamin D receptor resistance in patients with cancer diagnoses? And is that something that you know of playing a role in oncology treatment at all?
Yes, actually, I forgot to mention that at the beginning. If you test cancer patients, I'm sure the majority, if that's part of your practice, patients are low on vitamin D if they have cancer. And I think that's because of obviously intensity and severity of their their disease. It's very common to find that, and people who have been on higher doses of vitamin D, even starting with 10,000 a day, their condition immune system has improved. I think there's a lot of research around using it in cancer, and even oncologists are now more open to using higher dose of vitamin D. That regulates your immune system, right?
Right. Yeah, I know there's definitely some literature showing that replenishing vitamin D gives, you know, better quality of life and better prognosis for folks. I guess I'm just wondering, like, are you aware of clinicians who might be using, like, you know, kind of these mega doses of vitamin D as a synergistic factor or approach along with other interventions?
I'm actually not familiar with any. It doesn't mean that there aren't. It's just
Sure.
my
Yeah,
experience.
just curious. Yeah, just where, of course, with cancer, there's a big immune system component there, and I'm just wondering if the vitamin
Right.
D might be important for,
Yeah, very valid question. Yes,
Mhm,
I don't necessarily treat cancer per se. I do supportive therapy for cancer patients
mhm,
that to use conventional treatments, and I do put them on vitamin D,
mhm.
but I do not use super high dose of vitamin D. I haven't had the experience with that. When I'm
Right.
saying super high, I'm talking 50,000 and up.
Mhm,
Maybe some patients have used 50,000 a week or so, which is not very high, but
mhm,
for some people, 10,000 is a lot too.
mhm. Yes. Yeah, it's all relative, I suppose.
That's all relative, yeah.
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 Um, so before we kind of start winding up the conversation here, at which point I'd like to ask you about, you know, how folks can get in touch with you if they'd like to work with you. I'm just wondering, are there any other things that we haven't covered or things you'd like to share about the protocol that I didn't think to ask about?
Uh-huh. So what I want to say is that patients that are going on the protocol have to understand it's not a miracle cure, and not to give up too early with the protocol. Because what we've seen over time, it's the patients, right? It's to be patient and to follow the protocol guidelines,
Hmm.
and also work on other aspects of their life that have led them to this state. It is as important as vitamin D itself. So when we say vitamin D protocol, it doesn't mean just ingesting high doses of vitamin D. It means lifestyle changes. It's huge, and Dr. Coimbra emphasizes that all the time. The importance is as important as the high dose of vitamin D. It's just a vehicle to help you get to where you want to be, taking care of other parts of your life that are not in order.
Right.
And we already know, not to repeat myself, but we know what those components, mental, emotional is huge, as well as diet and lifestyle.
Right.
Exercise and emotions play a huge role in all these autoimmune disorders, as well as toxicity.
Right. Yeah, I suppose that kind of speaks to what you were saying earlier in the conversation that, again, it's kind of a chicken or egg thing, but if all of those lifestyle factors, et cetera, are so important, I think it suggests to my mind, at least, that they must be contributing to something happening with the vitamin D receptor that's kind of shifting it and altering it in such a way that it's not as responsive. So if you need that, otherwise be like, oh, it doesn't matter if you fix lifestyle things, like just the vitamin D is a miracle cure on its own. The fact it's synergistic with those other things suggests they must be having an impact on the integrity of the receptor itself.
Yes.
Yeah. Great. Well, if folks are listening and they're thinking like, by golly, I'd really like to work with, the person who's been doing this protocol in Canada for the longest, and they want to work with you, how can folks get in touch with you to help them out with their cases?
So I am at Vancouver Naturopathic Clinic, obviously in Vancouver, BC, and they can reach me through the office, 604-738-2111. We do have a website, and I have my own website, naturopathicclinic.com. And if they just enter my name, Dr. Sanja Tamburic, I'm sure they'll be able to find me.
I'll put the website and phone number in the show notes, and so it'll be easy to find you. And do you work with folks that are outside of BC in some way, shape, or form, like through case consultations with their primary clinician or anything like that, or is it only folks that are in BC itself?
Yes, because I am the only doctor doing this protocol, I am able to do remote consultations. Otherwise, patients are encouraged in Canada to consult with a doctor in their own province. Now that you're available, obviously, it will be easier. But other than that, I do work internationally with other people who are not in Canada as well, remotely. So.
Great. And so they can just kind of reach out to your office through your website or calling them and just figure out the details from there.
Yes.
Yeah. Great. Wonderful. Well, thank you so much for taking the time to chat with me today, Dr. Tamburic. It was really, really great. I was really happy to have the chance to get to pick your brain about this because I've been thinking about this protocol a lot. And so thanks for sharing your knowledge with me previously. And thanks so much for sharing with us today.
You're welcome. I'm glad you reached out to me and that we are spreading the word.
Me too. Well, thank you so much to everyone who's listening. This concludes another episode of the Overcoming Chronic Illness podcast, and stay tuned until next time.